Today's panel is one part of our observance of Pride Month, a time to affirm dignity, health, and belonging to the community. At Downstate, this is not a date on the calendar. It's more than that. It reflects who we are and who we strive to be. I want you to visit the Downstate YouTube channel this month to see two of our phenomenal people here. One is Dr. Cindy Benson, who's on our YouTube channel, and Dr. Sal Volpe, who is just graduating, class of 2025. So I want you to take a look at our YouTube channel. It's amazing, it's fun, it's wonderful, and please share it with your friends. Their stories show Downstate values in action, and we thank them for all they do. Now, a little more serious. Across the country, we're seeing efforts to limit gender-affirming care, curtail civil liberties, and silence LGBTQIA voices. These are not abstract issues. They affect real people now. And as an academic medical center, we must respond with leadership, not just words. Today's panel is one step in that direction, and it's a call to imagine care that is inclusive, protective, and rooted in justice. Our panelists today are some of those important voices. Mr. Alfonso David, President of the Global Black Economic Forum, who will join us by Zoom at noon. Dr. Cindy Benson, our Emergency Care and Hospital Quality Leader. Dr. Elke Jacobson-Dickman, our Associate Dean in Pediatric Endocrinology. Dr. Suzanne Rappaport, our Occupational Therapist, Social Justice and Arts Advocate. And Dr. Chris Ramon, who's also joining us remotely, an immunologist and mentor. These descriptive titles are just broad, but from their bios, you know we're dealing with some awesome people. I'd like to take a moment of personal privilege to shout out Dr. Jeffrey Birnbaum, who's unable to be here today, whose voice at Downstate is revered in gender-affirming care. We could not be who we are if we did not have a Dr. Birnbaum on staff. Just a quick thank you. I want to take that moment to say he's one of my personal heroes, and he is a hero to Downstate. And to all the folks that he provides care to, I'm grateful to him, as we all should be. So thank you, Dr. Birnbaum. I hope you're able to catch this at some point. Now, a couple of housekeeping rules. Please silence your mobile devices, and I need to remind myself to do that. Restrooms are located outside of the office here, outside of the room here. Media consent signs are posted, and if you prefer not to be photographed or filmed, please see someone in the back from my team. She will give you something to identify yourself, so we'll make sure to honor what your needs are. Now let's begin. I'm pleased to introduce our moderator, Dr. Efekona Nuwere, who is chair and assistant professor in the School of Health Professions. He's a licensed OT whose work spans medical rehab, assistive tech, and community health promotion. A dynamic educator, he champions inclusive learning and client-centered care. His research explores how social conditions limit participation, especially for older adults, and he believes therapy empowers people to live fuller, healthier lives. Please join me in welcoming Dr. Efekona Nuwere, and let's get down to business so that we can continue to keep care close in all that we do here at Downstate. Thank you. Dr. Nuwere.
Thank you, Dawn. Thank you. All right. Welcome, everyone, to Beyond the Binary. I'm delighted to be your moderator today for what we hope will be a truly engaging and nuanced conversation. As we begin, it's vital to recognize the incredible diversity and intersectionality within the LGBTQ community. This community encompasses a rich tapestry of identities related to sexuality, gender identity, and expression that is intertwined with aspects of faith, race, class, ability, and so much more. Understanding this layered complexity is fundamental to our conversation today and the work here at Downstate. Our discussion today is rooted in the pursuit of health equity, which means striving for a reality where every individual has the ability to achieve their full potential for health and well-being. It's true, there are countless factors that impede this goal, including historical and contemporary injustices, persistent economic and social obstacles, and preventable health disparities. These challenges are often exacerbated with a deep ingrained history of stigma, discrimination, and a lack of acceptance, whether within one's family or neighborhoods, or society at large, all of which hindered the LGBTQ community from achieving true health equity. So in this next hour or so, we'll go through a few segments with the panelists, exploring critical topics. Where, as Dawn had mentioned, we're expecting a special guest, lawyer, CEO, and president of the Global Black Economic Forum, also former president of the Human Rights Campaign, Alphonso David. We're happy that he will join us remotely later on in our discussion. So let's introduce our esteemed panel. To my far right, we have Dr. Cynthia Benson, Interim Medical Director and Director of Quality here at University Hospital. You can shout her out, give her a hand, I guess. Why not? We have Dr. Elke Jacobson-Dickman, Associate Dean, as was introduced, for Clinical Medicine and Associate Professor for Clinical Pediatrics in the Department of Pediatrics. Welcome. We have my colleague who works with me in occupational therapy, Dr. Suzanne Rappaport, Assistant Professor in the School of Health Professions and Program Coordinator of the Post-Professional Occupational Therapy Doctorate. Welcome. And joining us online remotely is Dr. Christopher Roman, Chair of the Department of Cell Biology and Associate Professor. Welcome.
Thank you.
So as we delve into our first segment and turn our attention to the crucial role of education and healthcare institutions in advancing health equity, these institutions bear a profound responsibility. And we must make it undeniably visible that we are a welcoming, affirming space for the LGBTQ community and for all people from all walks of life, all races, ethnicities, and all marginalized groups. This is not just a nicety, it's a necessity. When institutions don't explicitly declare themselves as LGBTQ affirming, individuals suffer in silence. They're left searching online, desperate for a provider or a center that signals safety. They carry the weight of past stigma and discrimination experienced in healthcare, making them understandably afraid to seek care anywhere that isn't openly affirming. I'm sure our panelists can bear witness to this when members of the LGBTQ community may delay seeking critical care or even academic support until maybe the issue becomes more advanced. That's why it's our responsibility to hold safe spaces that people can feel truly seen, spaces that affirm them. So with this understanding, we declare it's our collective commitment to proactively foster inclusive academic and clinical environments that support LGBTQ students, providers, and patients by providing care, education, and leadership development that advances health equity for the LGBTQ community. Essential to this work is the LGBTQIA+ Health Pathway Elective, developed and led by Dr. Elke Jacobson-Dickman, Dr. Christopher Roman, and as mentioned, Dr. Jeff Birnbaum. This elective offers first-year medical students in-depth instruction on inclusive and affirming care, using real-world stories from LGBTQIA+ providers and patients to highlight the human impact of bias, discrimination, and affirming practices, thereby building community support and advocacy. There's also the Sexual Orientation and Gender Identity Leadership Training, or SOGI, at the University Hospital, which is part of Downstate's broader efforts to promote inclusive learning environments for individuals with diverse identities. SOGI program empowers clinical and academic leaders to create and sustain affirming environments, providing the tools and perspectives they need to ensure that inclusivity is embedded from the top down. So these programs reflect a strategic and multi-layered approach to institutional change, making medical training more responsive to lived experiences, while linking education to broader social justice goals. So that brings me to the first opening question to the panel, to maybe share more about the impact of these educational pathways on student engagement and institutional culture? And how might that be a model that can be replicated or expanded across our different educational programs here at Downstate?
So thank you for that introduction, and I want to begin with saying that I agree this is much more than a nicety. It's not a nicety, it's a moral imperative. And it goes beyond making our learners comfortable in an inclusive environment. That's also a moral imperative. But when we talk about the impact, and I think at this point it's somewhat unexplored, it needs to be studied much more in depth and much more broadly. But what is the impact we're really looking to make, which is bettering healthcare, right? That's our institutional mission. What we know is that representation matters. What we know is that if we don't have an environment where everyone feels they belong, then they burn out. Then they don't want to come in the first place. Those that do come are less likely to be successful, less likely to find themselves in leadership positions. We want them not only to be plentiful and representative of the communities that they come from and the numbers in which they come from, but we want them to be the leaders. We want them to be involved in setting policies, in advocating, as we know is so necessary, on every level, not only in our region, not only in our healthcare institutions and our federal government, et cetera. So that comes down to why we focus so much in the medical school, and I'm sure in other colleges as well, and I'd love to hear more about that and partner more in the future than we do already. You know, in 2011, there was a really important JAMA article that came out that showed that medical schools are simply not teaching about LGBTQIA plus health. There were 20% of the medical schools in this country that weren't touching it at all, zero content. And the rest weren't doing great either. And when they were largely talking about very stereotypical, very stigmatized issues like HIV, like sexually transmitted infections, not sports or general health care, as all individuals require. Soon enough, the AAMC, which is our major guidance for medical education, came out and said, you know what, we need to have formalized guidance. So in 2014, they provided that. This related for the first time what they called climate change, which is really about the learning environment, which we focus a lot on. And that did make an impact. Okay, that did drive change. That did change the way people imagined they'd be credentialed, which carries a lot of weight. It wasn't good enough, ultimately, and particularly related to trans and gender diversity, there was a huge lag in change. And so here we find ourselves where healthcare really hasn't improved enough for the trans and gender diverse communities. Our school, I would say, was ahead of the curve. And even when I came here in 2007, we had some sessions. I'm not saying we were, perfect. And what those sessions were our students getting involved and sharing their own personal experiences. That takes so much guts for a person who's going through it to take it upon their shoulders to share their own interface with medicine, their motivations within medicine. And that's how we did it at the time. Then people like Dr. Birnbaum took over and brought in more content and brought in patients who were willing to share their experiences, and those are ongoing. And we find ourselves now, more than a decade and a half down the road, with quite a bit more content, and a lot of that comes from what we call reciprocal mentorship. So what do we know? We know that 43% of transgender individuals who are out and identified by census data are under 25 years of age. What does that mean? That means that individuals who are comfortable sharing their identity are probably comfortable with one another and have a little bit different attitudes in their, their feelings with working with and for transgender individuals. And so we've really capitalized on this reciprocal mentorship models and worked with our students to develop more content. Now we have content in every single year. We have gone to the AAMC and run workshops with our students. We have published, or we're in the process of publishing, some studies, including IRB approved studies here at Downstate. And lastly, what I want to mention is this pathway that you talked about, because I do think that this is enriching our community in many ways. So how did this come about? Was it my brainchild? Was it Dr. Roman? Was it Dr. Birnbaum? Nope, it was the students, okay? That's right, I will give them a round of applause. They came to us, a very special group, and said, this is what we need. This is how we want to do it. They had it all outlined. They couldn't have created this more professionally. And we said, okay, we'll get on board. And we did so happily. And I don't want to speak for Dr. Roman, but I think he can add to that as well. And what do? They addressed issues that we know from very small studies that individuals who relate to trans and gender diverse identities experience in medical school. And what are those things? It is largely around navigating what's called a cisnormative culture, a culture where it's the assumption de facto that somebody identifies as cis or somebody who is gender is aligned with their sex assigned at birth. Where it's simply not acknowledged in assessments, in standardized patients, in patient encounters, that different identities exist, and frankly, you don't know what they are unless you discuss that with the patient. And I got off track a little bit. Yes, so they acknowledge that these are issues that students experience, making them feel a sense of non-belonging. So what did we do? We got faculty. We asked folks, will they get involved? I see many of them here who are mentors, research mentors, clinical mentors. And you know what? Folks said yes, easily, happily. So firstly, it was about creating mentorship relationships, which we know is woefully lacking in these communities, okay? It's about creating research opportunities to better the care of our patients. It's about creating opportunities to go out into the communities and do good things there. And it's about extra opportunities to get better at clinical health care, particularly for trans and gender diverse and LGBTQIA plus individuals. The last thing I would say about that, because I do realize I'm going on a bit long, is that they have incredible didactics from experts all over the world that they record with the permission, and they make these available to the entire school community. So it's not a selfish endeavor by any stretch. This is really for everybody, not just the individuals who are chosen to participate. And by the way, it's quite competitive. Students apply at large, and the strongest ones are accepted. This week, I'll just share lastly, the teacher in the didactics was one of our recent graduates, okay? And I have to say, she did such a wonderful job and is going into endocrinology, finishing up her internal medicine experience this year so that she can be a gender-affirming provider. So,
Thank you. Thank you for sharing that. I thought it would be a good opportunity for Dr. Roman to jump in and share his insights with the Pathway elective.
So yeah, let me just say I concur fully with what Dr. Jacobson was talking about. I think a lot of what we're doing in the medical school, and I think in other schools on campus, is that we're trying to do harm mitigation as a way of creating a more inclusive environment where individuals from the LGBTQIA and other communities and the rich intersectionalities that we all have can really, not just succeed, but flourish. And, part of that is, doing sort of getting into the weeds about, is our curriculum biased? You need fresh eyes. You need a very diverse set of eyes and lived experiences to go through curriculum, let's say, and look at it for language, because language is dynamic. It could have different meanings, depending on how you've experienced that language. You also have to look for things like omissions, like what's absent, because I think what Dr. Jacobson was saying was representation, means everything. And can you see yourself in these vignettes? Can you see yourself or people, your loved ones, because it may not just be you, but your family, your adopted family. You want to see people represented with authenticity, with dignity, with respect, and not just the patients, but also your colleagues, your mentors, your peers in medical school, or any of the health profession schools. And I think part of that, and I think one reason why I really appreciate this panel is that I think developing these sensitivities across different healthcare professions is really critical, because we have to function as a team. I am not a clinician, right? So I think my value is that I bring a naive perspective to the medical school curriculum and sort of medical culture, and how I've had to intersect with that, personally and professionally as a scientist and as a departmental leader. And so you also have to think about, you mentioned the word politics before. Science shouldn't be politicized, but we know that it is. And we teach an evidence-based curriculum. We rely on robust scientific studies, scientific research to develop a body of knowledge that we call evidence on which to base a practice or a hypothesis to develop a new drug or a new occupational therapy or something like that. But if your healthcare concerns or your group, the group of individuals that you consider yourself belonging to, are not valued, then why would the public want to invest scarce research dollars in supporting research that would help address, your needs? So I think that's part of what we try to do collectively, is to really develop a very robust, in-depth look at what it is that we're teaching, what are the foundations of it literally, and where are the intervention points. If we're trying to train the next generation of healthcare providers, what are we preparing them for professionally? What does that world look like, and how can we help them develop a resiliency to face that? To know that they have people who got their backs, that they're not out there alone, but they have a community. So all of those things factor in when we're talking about a pathway. Working at a place like Downstate, where our leadership has been incredibly supportive. That means everything. So I think that's what I can add to what Dr. Jackson-Dickman said so far.
Thank you for highlighting that aspect. And as you were speaking, I'm reminded of this point related to LGBTQ individuals. Often the emergency department serves as their first or even sole point of access to care. However, these critical encounters can be severely impacted by the fear, stigma, misgendering, overt discrimination. And it's not that people avoid care, but instead they make rational choices based off of the personal experiences they might have. So, why would someone seek help in a hospital if they anticipate being turned away or being treated unfairly just because of their identity? And unfortunately, emergency settings frequently lack these standardized protocols, staff training in gender-affirming care, and trauma-informed approaches, which often leads to delayed care or even just avoidance of the medical system altogether. So Dr. Cynthia Benson leads with culturally competent and inclusive care within the ED. Her leadership has elevated institutional conversations around inclusive training, trauma responsiveness, and the development of affirming protocols. Her efforts highlight how emergency care settings can evolve into safe, affirming points of entry for LGBTQ individuals in crisis. And then when we see on the education side, Dr. Suzanne Rappaport work addresses long-term systemic change by equipping future occupational therapists with the tools and insights necessary for transgender and gender nonconforming clients through workshops, mentorship, and ongoing research. She is advancing inclusive care models that help dismantle bias and structural barriers in everyday practice. So, my question to you, Dr. Benson, is, your leadership in the ED is crucial given that it's often the first point of contact. Can you share any specific challenges you face in elevating this issue of inclusive training or affirming protocols within the emergency setting? And perhaps what was your most effective strategy in overcoming that?
Thank you for the question.
Yes.
One of the things I just want to reflect on what both of you said and the importance of the integration of the pathways that you've created is that for me, one of the things that happens is that it starts to normalize things that have been stigmatized. And I think as healthcare providers and in the next generation of healthcare providers across all the disciplines, when things are normalized for the physicians and the occupational therapists and all the people that participate in the healthcare landscape, what that does is that takes some of the burden off the patient of having to normalize it. So imagine you're sick, you're stressed, whatever it has brought you into healthcare, and on top of that, you have this extra added burden of trying to explain or justify or normalize who you are. And that's just an extra burden that nobody should have to have. So I think starting the conversation around education is essential. And I think it's going to take time, like it does with all things that need to be normalized within our society. It's going to take time to percolate through all the generations of people who practice healthcare. But I think it's very important to tackle kind of from both sides. In terms of specifically in the emergency department leadership things, I really credit the hospital, University Hospital Downstate, and their leadership for the Shoji initiative, for instance. I think that is something that as an institution, again, it starts at the top and it trickles down through all the different departments. We have partnerships in the emergency department with lots of different programs. I see some of my colleagues from STAR and participating with HEAT. I had an encounter not long ago with a patient, a young woman who needed health care. It wasn't gender affirming, but it was sort of family planning, and I was talking to her about the different options, and HEAT came to mind. I pulled up the website, and there was something that literally was targeted towards this 17-year-old woman, and addressed her sort of about her healthcare. And when I say her face changed when she's looking at my computer, looking at the website, and all of a sudden she's like, yeah, I would go there. I would go there to get healthcare. It really cemented, it cements, it's not the first time, but it just over and over and over shows how much representation matters, how important it is to have people who look like, who are like, who behave like the patients, serving the patients, because that message goes, it just is, it's beyond words what that does, and how it frees up the space for people to actually address what their concerns are, and so they don't have all these extra layers that you have to work through.
Thank you. Dr. Rappaport, you joined us probably just over a year ago, and I've really been admiring your work. You've been kind of just from the beginning all about inclusive practices in education, and as an educator focused on holistic and person-centered approaches. What are the most critical strategies for equipping all future healthcare professionals across disciplines to dismantle these barriers and assure affirming pathways to ongoing care?
Well, thank you for saying you admire my work. That's good to hear. as far as, I feel that as being an educator, it's another platform for advocacy. And we forget that. We don't, I mean, you can go to the No Kings rally and that's a form of advocacy, but I'm in a position of power as an educator. So for me to be mindful about how I'm offering presenting the syllabus, I always review it to make sure everyone is represented, and having good case scenarios that represent all. And when you think about diversity, equity, inclusion, but also they have DEI and DEIB for belonging, is like, do people feel they belong? And what is belonging? But then making sure I'm very mindful of that line, that if, I want to make sure everyone's included, but I also don't want to tokenize someone in the class, to say, hey, tell me about this experience. Oh, I'm putting you on the spot. Because as you mentioned, it takes courage to be there, and being mindful of that.
Thank you, thank you. I believe, are we joined by, yeah? So that kind of set the ground for the conversation, starting with what's happening here at Downstate and the education. And I want to take sort of a broader view in terms of some of the things that are happening legally. And for that, I want to welcome Alfonso David, not to be confused with Alfonso Davies, which I found out. I don't know if anyone's familiar. Alfonso Davies is a Canadian footballer who plays left back for Bayern Munich. But this is Alfonso David, who's also of Liberian descent. And Mr. David, in your own right, you are known for your vigorous defense of civil rights and your trailblazing pace in advocating and advancing social and economic justice. So we're glad to have you here today to share your legal and your national insights.
Thank you so much.
So just over a week ago, the U.S. Supreme Court issued a 6-3 decision upholding Tennessee's law, SB 1, which bans gender-affirming care for transgender youth. Drawing a parallel with the Dobbs decision, we have another instance of the court restricting access to evidence-based medical care that people need. And just to catch people up, the Skrmetti ruling makes it more challenging to overturn similar bans in other states. It does not ban gender-affirming care nationwide. They avoided setting a precedent beyond healthcare. The court concluded that SB 1 does not discriminate on the basis of sex, viewing it instead as a rational regulation of medical practice. This decision significantly impedes a key legal pathway for challenging other trans healthcare bans, specifically those grounded in sex-based discrimination under the Equal Protection Clause of the 14th Amendment. So in light of the court's decision, Mr. David, and the administration's efforts to restrict coverage of gender-affirming care through federal insurance programs like TRICARE, VA benefits, the Affordable Care Act, what are your thoughts on blue states and cities like New York City and their ability to leverage their position and resources to proactively reclaim the fundamental right to access to best practice in medical care, ensuring not only safeguarding and expanding of existing gender-affirming care within their jurisdictions, but also fostering a broader movement that affirms the right across the nation?
Well, thank you. Thank you for the question. And I'll start by saying that in this current moment, political moment, cultural moment that we live in, it's important for us to be grounded in history. Although the circumstances seem dire, and especially for young people and others who are in need of medically necessary care. But I also think it's important for us to put it in context, because not too long ago, we lived in a country where your rights depended on your geography. Based on where you lived, you had certain rights and protections. And unfortunately, I think that is the direction we're going in today. As you referenced, we have 27 states that have enacted some type of legislation to ban gender-affirming care for minors. Now, with respect to those 27 states, they will be akin to the states that prohibited interracial marriage, or the states that prohibited same-sex couples to marry, or in some instances, the states that advanced slavery. We've unfortunately seen similar patterns with respect to the tensions between individual rights and individual liberties compared to what is often framed as states' rights. And to answer your question directly, I think what we're going to find is that the quote blue states are going to have to be a lot more forceful and strategic in how they are advancing and protecting individual rights. What I mean by that specifically is, under the US Constitution, it serves as the floor for protections that we all have under the US Constitution. But state laws and state constitutions specifically can provide greater rights than the US Constitution provides. So to put an even finer point on it, this new decision that was issued by the US Supreme Court, and as I referenced, 27 states have enacted these bans, but you have 2 states where those bans are actually being challenged under their state constitutions. So you have Montana and Arkansas. And in the US Supreme Court decision that you referenced, they were challenging whether or not the Tennessee ban violated the US Constitution. And the court concluded that it does not. But the bans in Montana and Arkansas are being challenged under those states' constitutions, not under federal law. And as a result, the courts in those cases have actually issued bans or injunctions or blocks against those bans being implemented. Because again, we can provide greater protections under state law than under federal law. And then also an important additional factor are the claims that we use to challenge these bans. So the US Supreme Court case was based on the Equal Protection Clause, right? And the Equal Protection Clause, not to get too legalistic, has 3 different tiers: strict scrutiny, intermediate scrutiny, rational basis. So if there is a law that's passed, the courts evaluate whether that law discriminates against a certain group of people based on those tiers. So race is strict scrutiny. Heightened scrutiny is generally sex. Everything else is rational basis. And so in this case, some were arguing that the court should evaluate the ban based on intermediate scrutiny, which is sex, what we call heightened scrutiny, because then the burden on the state is greater. They have to show that there is a heightened interest that the state has to issue these bans. But the court said, no, this is not about sex, right? This is based on science. This is not based on sex. And so as a result, if the state has any rational basis for issuing these bans, then we don't think it violates the Equal Protection Clause. That's one legal constitutional construct. There's a separate one, which is due process. And the 2 states I mentioned, which is Montana and Arkansas, essentially those laws are being challenged on due process grounds. They're being brought by parents who are stating that the law took away their ability to make decisions regarding their child's health care. That's a very different legal claim than equal protection. So the states, the blue states, if you will have to really think more forcefully and aggressively and strategically about how they advance healthcare for all. And if those principles or practices are challenged in these states, they also have to be strategic as to what claims they're going to be raising in defense of those arguments that are raised.
As I'm learning more about this issue, yes. I'm learning more about the arguments, and you just mentioned due process. For me, I'm understanding as you had said, this ruling is getting in the way of parental rights. And I wanted to turn it to the panel. If perhaps if you're familiar with the Scammetti decision, maybe make it real for us. What examples from your practice or even the classroom may powerfully illustrate this impact in providing gender-affirming care, working with families to address their medical need that they've demonstrated.
I think at this moment in New York City, a lot of the parental concern is about this radiating changes in that autonomy to work with your provider, with your child, to make the decisions that are in the best interest of your child. I think there's a lot of fear on an organizational perspective to comply with federal edicts and ideology even before that the law mandates. We spoke about Dr. Birnbaum earlier, and I think that's a perfect example of other organizations, which I won't name, whose knee-jerk reaction was to, I'll say it, ghost patients who, children coming in for care, just cancel. No discussion, no call from the physician who they, hopefully have a relationship with. Meanwhile, our doctors, like Dr. Birnbaum, it's no secret, it was in the New York Times, said, I'll go to prison before denying my patient equal care. So I think what we see here are, even if it's legal, organizations reacting to that threat, because the federal government does provide funds, in either directly or indirectly, which really do turn on our lights in many cases. On a personal level, I have a child who's gender nonconforming. I have many friends who have children who are gender nonconforming, who are being told by physicians, get a year's worth of medications because we don't know what's going to happen. Places like Massachusetts, places like New York City, where we generally think of ourselves as not in the category of states that were mentioned earlier.
Now, I don't have experience with, I work with adults who are transgender and gender nonconforming. And then I used to work in a school system when I worked clinically as an occupational therapist. But this was over 8 years ago. So to know some of the parents, to know that they can see if their gender isn't affirmed and the crisis that their kid is in, that this is probably very devastating. And it's a similar, to me, I view it as a similar thing as the abortion bans, that people might have to go to other states to get the medication they need. And that becomes an equity issue. And just that, to see a kid when they were affirmed and how they started to thrive in the school system and now not have access to those things. And then, of course, like, the federal government is involved in schools as well, and seeing that layer. And when the legal document of an individualized education plan that I was writing as part of the team as an occupational therapist, of like, this is the legal name, this is the preferred name, and coming around with those workarounds. But we did use the workarounds.
I want to transition to something, Dr. Jacobson, you mentioned earlier about maybe stereotypes, if I can call it that. For too long, the mainstream health conversation about the LGBTQ community has been narrowly focused on HIV/AIDS. And while HIV has disproportionately and devastatingly impacted this community, and many individuals continue to live with its realities, it's crucial to understand that the LGBTQ health cannot be reduced to a single story or legacy. So in moving past stigma, it's imperative that all medical specialties recognize and integrate LGBTQ health into their practice. Understanding this broader context is key to truly providing comprehensive affirming care. Yeah. With that said, the landscape of HIV treatment is continually evolving. The recent FDA approval of lenacapavir, you know I practice this, lenacapavir, twice daily injectable, yes, twice yearly injectable, marks a significant breakthrough poised to reduce health disparities and improve lives by addressing barriers like adherence or stigma. And furthermore, efforts like the $32 million partnership between the Health Rights Campaign and Gilead Science, championed by Mr. David, actively transforming HIV efforts, specifically with Black, Latino, and transgender communities, ensuring innovations reach those most at need. So, Mr. David, given your leadership in transforming HIV efforts within marginalized communities, how do you see the ongoing Braidwood case impacting access to critical preventative services like PrEP? And what are the broader implications of HIV prevention and health equity for those should the Supreme Court rule against the ACA's preventative services mandate?
Sure. So for folks who may not know, there is a lawsuit that is now before the U.S. Supreme Court. In the case, the plaintiffs are arguing that the Affordable Care Act preventative services requirement, which I'll explain in a few minutes, they're arguing that that provision under the Affordable Care Act is unconstitutional because it violates a few different doctrines, is what they argue. The preventative services requirement is very popular. It has been in effect for more than 15 years, and it effectively extends coverage to evidence-based preventative services. So we're talking about cancer screening and tobacco cessation and contraception and immunizations and the like. So it provides coverage without cost sharing. So 150 million people a year have access to these services where they don't actually have to pay an additional fee for it. If the court concludes that this requirement is unconstitutional, this benefit that has been in effect for 15 years is going to go away. So what they're arguing, and there's 6 individuals in a Christian-owned business. It's a for-profit organization, but they're arguing that they shouldn't be required to provide these types of services or pay for these services because they believe that they violate their faith. So the potential impact of this decision is quite significant because the preventative services talks about sexual and reproductive health. So we're talking about HIV infection, we're talking about PrEP, we're talking about potentially aspirin that could be used to prevent certain types of pregnancy-related or affect certain pregnancy-related conditions. And if this provision is struck down by the U.S. Supreme Court as being unconstitutional, what we're going to find is an impact on marginalized communities that are seeking access to PrEP. I unfortunately, and I think others in this room probably have known people that have passed away from HIV/AIDS. And the communities that are disproportionately impacted happen to be poor and Black and brown. And to some extent now, women of color are disproportionately impacted by HIV. So there's stigma, there's misinformation, and if this law is struck down, we're going to have a significant access problem. Because if you can't get access to preventative services, such as PrEP, then you're either going to be forced to use contraception, which, by the way, which may also be challenged. And then what we're going to find ourselves is struck between a rock and a hard place, because you can't use preventative services and you're going to then be subscribed to engage in certain conditions or practices that are aligned with certain religious doctrines. And that's the main concern. There are going to be accessibility issues that are going to disproportionately impact people of color and women. And in addition to that, it's going to affect our conduct and our behavior in our lives. So for folks who are thinking about this lawsuit as just being about preventative services, I often say that is more than that. It's about how we're going to live our lives, and it's about how we're going to define our practices being either legal or illegal.
Considering what Mr. Davis mentioned to the panel, have you sort of witnessed, or what can you think about the most profound implications this new drug that's on the market in addressing existing health disparities, particularly within marginalized communities affected by HIV?
So as an example, we had a meeting yesterday with our partners in the STAR Clinic to talk about how we can bring PrEP to the emergency department. I think one of the ways that we can combat some of the current challenges, the future challenges, is to be more forward-thinking in the delivery of care and to utilize within the boundaries of the the things in the legislature that we have to conform to, but how can we really find the edges of those and think about delivering care that maybe has always been assigned in one place to different places, and figuring out how to do that safely, how to do it in a way that's evidence-based, figuring out how to do it in a way that is very patient-centered, and takes away some of the traditional, like, oh, we do this way because that's how we do this thing, taking a lot of that out of the equation and figuring out, all right, if we know that patients will come to us in the emergency department when they reach a point where they feel like that's the best option or the fastest way to get care, how can we screen, how can we maximize for the time that we have them, and offer lots of different types of care that maybe it's too difficult or too challenging to get into a different environment. So for us in the emergency department, we try to think about it in that way of stretching our boundaries a little bit. It becomes kind of a catch-22 sometimes, because that sometimes means emergency departments, which chronically experience overcrowding, like, now are we going to sort of encourage more folks with non-emergency conditions? But I think if you were to ask the faculty in our department, would you rather just try to limit care to just those with emergencies, or would you rather try to help as many people as possible? I think you would universally get the answer that we want to take care of as many patients as we can, as efficiently, as effectively, as safely as we can, to give them the best healthcare options. So I think it's about, and kind of like what you're doing with the medical school curriculum and the OT curriculum, is turning it on its head a little bit, figuring out what's salient, figuring out how to reimagine that, and then implement it in creative ways.
Okay. Mr. David, your career exemplifies a remarkable willingness to push boundaries and take bold action. You have a pioneering history of working on groundbreaking cases and initiatives across public, private, and non-for-profit sectors. And this includes landmark legislation like New York's Marriage Equality Act, the Paid Family Leave Act, the Minority and Women Business Program. Your work also drove crucial criminal justice reforms, including solitary confinement litigation, raising the age legislation, and restoring voting rights for parolees, as well as fighting to sustain the Fearless Fund, which aims to support Black women entrepreneurs in the venture capital space. So as we look to the future, a fight for full equity and liberation, particularly for the LGBTQIA+ community, is far from over. And as you had powerfully stated in your speech at the National Black Pre-Law Conference a few months ago, the law and social norms we live in aren't permanent. We have to fight for them or they will change. And you asked the audience to consider their own risk tolerance. So, Mr. David, given your profound understanding of that social progress is fragile and must be actively defended, what principles guide your own formidable risk tolerance?
There are a few things for me that drive me, and one is history, and I started with it, and it's important because it's easy for us to complain about the current circumstances we live in, and I don't want to minimize it, but I do think it's important for us to put it in context. And when I think about our ancestors collectively, and what the conditions that they lived in, and when you think about that through the lens of women who were not considered full citizens, or Black people, or brown people, or indigenous groups who were killed in order for us to be able to have this conversation today. It reorients me into thinking about how important it is for us to continue to strive for equity. And we will not win every single fight. In fact, we're supposed to lose these fights in order to strengthen our resolve and be clear about what's important and what's dispensable. We will continue to fight for equity. We will continue to fight for equality, but I think we also have to just incorporate this idea that, yes, there will be setbacks, and we have to make sure that we are strengthening our resolve and making sure that we have the tenacity to continue doing the work that we have to do. Because this is not just about me, obviously. When I'm up at 2 a.m. looking at a legal brief or thinking about whether to take a case or to get involved in an initiative, it's really thinking about the next generation, and it's thinking about how do we create a space that's better than the space that we currently occupy. And doing that work every single day is certainly not easy, but I'm encouraged by the perspectives of younger people, by how they frame issues and how they think about the world is obviously different than how we do, and is supposed to be. And I think that gives me the perspective of the continuum that we're on, but also thinking about how do we continue this work, getting up every single day to do it, and understanding that there is an arc. There is an arc, and we're on it. And yes, we're going to lose some fights, but we're going to win others. And ultimately, we will get to that place that we don't recognize right now, but we will get to that place that we call ultimately liberation, where there is equity and there is equality in a way that's actually true and realized. So that's what keeps me going, and what keeps a lot of the folks that are in this movement that I'm in going as well.
Thank you. I also wanted to turn it to the panel. So maybe you can share how you cultivate similar courage to advocate and push for equity within systems, within your own practice, or even encourage your students to do the same.
Well, I am beginning to suspect that we might be in the wrong timeline. But as terms of like having hope and courage, I try to remember that sometimes if you look outside of medicine and healthcare, but to other places like the arts, that there is change happening. Cola Scola just won a Tony Award for Oh Mary. Look, yeah, we could clap for that. Laverne Cox is in a sitcom about a transgender person and their experience. Like, there are things happening in the culture, and sometimes the world in the arts gets there first, and then the other people catch up. So remembering that there is representation, you know, and I try to imbibe that and have hope.
I think for me, I just, I cannot stand when something isn't fair. It really irritates me. And so, although that's a very positive way, both of your examples for what gives you courage is very positive. I think mine's a little bit more negative. Like, it's not fair. Like, I get angry. I stomp my, you know, I want to stomp my feet. I think that is what drives me when I can look at a patient who has a negative health outcome that they don't have to have if they had exposure to better primary care earlier, or somebody who saw them, where they didn't have to fight for their health care in such a way, and that took away from actually finding the underlying problem. Like, that can't be. The world is hard enough, like, in a lot of different ways. We have to work to make those things go away, because bad things do sometimes happen. You know, people get sick with diseases that we can't cure, and that's a really hard thing, but we can make these other things better. And the injustice of that is really what drives me to work in our little microcosm to make things better.
I'm the last to take the mic because don't think of myself per se. Oh, I'm sorry, Dr. Rahman. I don't think of myself particularly as brave. So, in terms of just what motivates, I would say, it's a combination of responsibility and acknowledgement of privilege, and being a doctor, and being a parent, and being, a medical education leader, are all incredibly privileged places to be and carry, in my estimation, great responsibility. And I think that's what motivates me. I mean, we owe it. We absolutely owe it. It is our absolute imperative to make things fair and just for our children, for our patients, and for our students. And that's, to me, that's just, doesn't take bravery, it just takes responsibility.
I think for me, it just boils down to one thing. It's, I love my students, I love my faculty, I love my community. I will do everything I can to make sure that they feel safe, they feel seen, they feel respected, they feel loved, and that they need to be here. Thank goodness you're here. That's very motivating.
Thank you. I wanted to open up the floor to questions from the audience. I think the mic is going around, or? Oh, sorry.
This is why I fail at this.
Hi, my name is Dr. Rio O'Meary. I am an attending physician in the STAR clinic that provides the majority of the primary care for HIV-positive patients and gender-affirming care for adults in the institution. HEAT does see some adults, but we see kind of the 30-plus. We see 18-plus, but we see most of the 30-plus in that kind of population range. And I kind of wanted to say two things. First is I just kind of wanted to comment on your lenacapavir question and answer that from the HIV specialist perspective. And then I had a question for Mr. David. So in terms of lenacapavir, which was just approved by the FDA to be twice yearly injections for PrEP, aka HIV prevention, I think that this is hopefully going to be something really meaningful. I think one, yes, it'll be great in emergency room settings if they're able to, administer that. But also I think it's great in the primary care setting because currently we have two options for PrEP. We have an injectable that's every 2 months, and then we have pills which are once a day. And having to come into a clinic every 2 months is a real difficulty for a lot of patients, especially if you're working, right? Most people are guaranteed sick days, but even a lot of my patients, who are working for the government say that they have difficulties coming in every 2 months and that they're getting, their supervisors are mad at them or HR is, telling them that they're taking too many sick days. So the ability to come in once every 6 months, I think, is huge for the working population. I also think that if you think about incarceration or jails, right, that's a great place to be able to implement this treatment. Or for people who are experiencing homelessness and, providing it in clinics that are associated with shelters, right? This medication is once every 6 months, and unlike the current injectable that we have that's every 2 months, the lenacapavir isn't a basis for the majority of HIV treatment, and so if someone were to get resistance to lenacapavir, it's not going to impact them in the same way that getting resistance to the other medications that we currently use for PrEP would. My question for Mr. David is, we were talking about red, blue states and how it's really about the state constitutions. So how can we be advocating within New York State specifically to make sure that these laws are codified into our constitution, such as being able to provide gender-affirming care for minors and being able to access preventative care paid for through Medicaid?
Thanks for the question. I think there are two ways to approach this. And when I was in government, we were able to codify the protections of Roe into the New York State Constitution. But in order to do that, you need to have it go through two legislative sessions, and it has to, of course, be presented to the voters. And I think that is an extensive process that sometimes the legislature may not necessarily be open to adopting, but that is certainly an option where we can take certain principles that we think are important and reflective of the values of New York and make sure that is incorporated into our Constitution. So we can do that. The second is to pass legislation and specifically reference the New York State Constitution in it. So when I had the privilege of writing the marriage equality law, one of the things we did there in extensive debates with some religious-based organizations is they wanted us to essentially amend the bill to allow individuals who had religious objections to marriages between same-sex couples, and they wanted us to incorporate it into the bill. And I said, absolutely not. We're not doing that. And they said, well, we don't think we should be forced to solemnize marriages. I said, yeah, you're not. The New York Constitution is pretty clear on that, separation of church and state. If you're a religious-based organization, you're not required to solemnize a marriage between a Jew and a Christian, right? Or between a Muslim and a Jew. You're not required to do that as a rabbi or as a priest. So we're not putting that in the Constitution. But what we did instead is to say nothing in this bill should supersede the New York State Constitution, which was essentially writing the existing law into statute. You can do it in the reverse as well, where you're referencing New York State law as being, or the Constitution as being the basis for the protections that you're providing, so that if there is a constitutional challenge, it has to be brought under the New York State Constitution as opposed to someone arguing that it violates federal law. So those are just two different approaches that you can use, that we used when I was in government, and I think are still applicable today.
Hi, my name is Michael Myers. I'm a psychiatrist here in the Department of Psychiatry. I want to thank the panel, and I want to thank the planners of this very, very important session. The past week, what I've been struggling with, one of my areas of subspecialty is suicide prevention. And when the funding was cut to the Trevor Project for the 988 number, my heart sank. I'm a past president of the American Foundation for Suicide Prevention, New York City chapter. And it took us years to get a 3-digit number. Because I was thinking all along over the years, when somebody's in a suicidal crisis, how do you dial all of those numbers, that kind of thing? And then to have this ripped away, in such a short period of time, I think I'm still in shock, because this is, the Trevor Project, as many of you know, is the specialty for the 988 calls from LGBTQIA plus callers. And so just recently, our chief medical officer, Dr. Christine Moutier, spoke to somebody, and she's at the AFSP as to where do we go from here, because it's going to involve a huge educational effort for the general 988 number itself and bringing people up to speed, which I think is doable, but it's going to take time. But one of her recommendations is that when and if we're suggesting that people use that number, to alert them to the fact that they may need to call sort of more than once or something like that, because for so long, you know that somebody at the other end of the line is with it. They hear you, they see you, even though it's over the phone or something like that. So, Mr. David, do you have any hopeful thoughts on this one? Because you're able to take this wonderful long perspective, and I really envy you.
Well, thank you for that. I do. I remember working at Lambda Legal a number of years ago and there was something, and I think it still exists, called the help desk. And this Lambda Legal is a not-for-profit organization that essentially works on behalf of LGBTQ people, bringing litigation around the country, impact litigation. And in this moment, I think about the importance of the private sector and the not-for-profit sector stepping up. You know, we don't know how long this period is going to last. And I don't want to get into that because there are all kinds of theories. But assuming it's going to last the next 4 years or the next 8 or maybe longer, in terms of not political, but also cultural, we have to think about how do we create and widen the aperture so that we can provide and supplement the services that no longer exist through the lens of private and not-for-profit partners. There are models that have existed for decades and that work very well. Public-private partnerships, not-for-profit partnerships with private sector to sort of supplement these services and make sure that people know they exist. I'm a huge supporter of the Trevor Project, and the fact that so much of their funding has now been removed, essentially gutted, means that the only other option would be for the private sector or other organizations to pool resources together and really think about how do we message the fact that these services still exist, that if you are in need, we're here to help you. And I love your idea about having a follow-through in terms of if you call back. I think a campaign and coordination with all of these different parties is going to be important because we've unfortunately had setbacks before and we've had to do similar things.
Okay, we have a question from the chat. Gabe Rodriguez says, as government sources of funding for this critical, I imagine, care disappear, how do we make the case to the philanthropic community that they must help us when they are being pulled in all directions?
I've been somewhat critical of some portions of the philanthropic community because I think there is a lot of fear right now that many that are in the philanthropic community that are fearful of taking action because they believe their 501c3 status may be compromised. I believe that failing to take action means that we're going to effectively adopt a new model where you can no longer provide these resources and services to the communities that need it. And what I often say is, let's take a step back. Charitable organizations have a constitutional right to issue grants and services to individuals and demographic groups that are consistent with their mission. That is the law. And if we don't solidify those protections, we will have them chipped away. Right now, you have organizations that are filing lawsuits against other organizations because they are providing services to Black people, or services to trans people, or services to LGBTQ people, when in fact, those services are directly tied into their core mission. And so we're in this space of reacting to these lawsuits as opposed to being affirmatively aggressive and making sure that we solidify those rights. So I do think this is a moment that requires some courage for those that have extraordinary resources to challenge these principles, because ultimately, you know, the First Amendment protections are applicable to the Heritage Foundation and the Ford Foundation, regardless of your political stripes. Because if we are going to then say that this is about viewpoint, then you no longer have a First Amendment right to issue grants consistent with your mission. So I think for me, that is what the core tension is. We're either going to be reacting to these challenges or we're going to affirmatively challenge the idea that philanthropic organizations have a constitutional right to do the work that they do.
We have another question over here.
Hi, everyone. Alicia Goodridge, Government Community Relations. So happy to see this panel. I love my Dr. B. That's what I call her, Dr. Benson. And I wanted to say something because growing up in this community, being Caribbean and American, and as a Caribbean, you're not an adult till you're like 25. They don't care. 35. So when Dr. Benson said she was talking to a 17-year-old woman, in my head, I'm like, that's not a woman, because we were still considered children. Even now, I'm 22 now. Y'all supposed to, thank you for the laughter, thank you. That, you know, it starts there. Giving respect at a younger age, that they are involved in their healthcare. I think that hit a point that made me even love you even more, because it's like, she gets it. And it makes a difference. That's not the question, but I had to acknowledge that. As my colleague says, point of privilege, let me bring that up. Because I have to, we have to give the flowers and acknowledgement for those small things, and being in the room for the heat celebration. And all. It's like, this is why I'm here. In my 4th year, I'm like, yes, Downstate gets it. You want to say something?
Thank you. I think what I'll say is that as someone who experienced not being fully seen for a large part of my life, the feeling that you get, and I guess you kind of pointed to this, or you pointed to this with kids, that when you see how it changes someone to be seen and to acknowledge that person for who they are, what an incredible gift to be able to give back. So I think it's, we are all individuals. We may not agree on every single thing, but as I like to hear people say, and I like to remember and remind myself, we are way more aligned than we are different. And so finding those moments to interact with people, to give them their space and their grace and acknowledge them is probably one of the best parts of my job.
And that's why we love you. Kudos. Give that a hand clap. So the real question, how does access to timely evidence-based gender-affirming care influence mental health outcomes, particularly suicide prevention, among transgender and non-binary youth? And what role should healthcare institutions play in ensuring this access despite shifting political landscapes? That was a mouthful.
All right, who wants to take that on? That's a big one.
Well, I might ask you to repeat part of that, but in some work that I've done with transgender and gender nonconforming healthcare, I can't remember the exact statistic because it's in the PowerPoint. I put it there so I can remember it when I give the presentation. But it was a high percentage of people when they were gender affirmed, like they were happier, even if they were, and this was a statistic that was in a workplace, that when they came out to their colleagues and then were affirmed, even if the bullying continued, they were still happier. And I know you had a second part to that question, but that was.
I don't even know. Thank you. the response. That's why I have a doctor right next to me. And what should healthcare institutions play in ensuring access despite shifting political landscapes? I think this conversation starts it. And then when this work is done by what you mentioned, Dr. Jacobson-Dixon, that we have an additional conversation, more work done. But I think if we continue the conversations, introduce it, let those students speak on why they started and talk about their interactions and all the pieces that they did, it gives them a platform to show that we respect and are grateful for the work they're doing, because it's going to speak volumes, here and nationally once it's put out.
Yeah.
And I would add, we actually have to provide the care. We have to provide the care, and we have to be brave about advertising that we provide the care. Because if we can sit here with the expertise, and if folks don't know we're here, they simply won't come. And that, unfortunately, takes some bravery in this day and age, as we saw quite recently.
And just to add to that, sometimes to signal to others that I'm like maybe a safe provider, or that I am a safe, not maybe, I am a safe provider, I have something that's rainbow on that might indicate, and they see that. They see that transgender sticker, the pronoun sticker, the rainbow somewhere, just to sort of signal.
I wanted to jump in, I'm sorry, because that made me think about something I saw in preparing for today, how HHS will not enforce the collection of SOGI data from medical records. And we are here as educators, as clinicians, but this infrastructure is very big. As soon as you walk in a hospital, you'll see receptionists and maintenance people and all across the board. So and at each point, something positive can happen or not happen. And so I was just curious about how perhaps this collection or the lack thereof collecting this demographic data impact both the clinical care that's provided, but also the broader public health initiatives aimed at addressing these disparities?
So accreditation and collection often changes practices. CMS was requiring that this data be collected. That made a big change. From our perspective here at Downstate, this is something that many of the folks in this room have worked on, and it was very aligned with our mission, so it was embraced. I think without the lawful or collections imperative, it will unfortunately impact many organizations. I don't believe it will impact us because we still believe and we still practice collecting those data so that we can address our patients respectfully, so that we can make sure they feel comfortable and that they can be seen.
Dr. Whitney Foster.
Hi, good morning, everyone, or good afternoon. Thank you so much for this forum and this brave space. So one of the questions that I have, so we see how these racist, unjust, discriminatory policies, we got to call them what they are impacting healthcare and research. But one concern that I have is also it's impacting our future educators, our future physicians, our future leaders, our future Jeff Birnbaums, our future panelists, because students are afraid. Future students, prospective applicants are afraid to even identify who they are on their applications. I've had students say, I was told by my pre-med advisor, you can't say that on your application. And I said, well, that is who you are. You have to be proud of that. But at the same time, I can't promise them that a reviewer may look at that application and basically they're biased against it. So how do we make sure that our future panelists, our students who feel safe and share who they are in their applications? Like, how do we speak to the future generation? Because that's one of the things that we're proud of. And Dr. Clinchy, remember at one time he said that when he interviews students and they talk about Downstate, and they want to come to Downstate because of the Pride Club, they want to come to Downstate because of heat, they want to come to Downstate because of the LGBTQ pathway. How do we continue that and reach out to those students who are not even here yet? Because that's what I'm really concerned about, how this is impacting even what students put on their applications. I don't know if there was a question in there, but I just wanted to share that.
Well, I'm right there with you, and this is an entirely evolving landscape for so many of us, and opportunities like this give us the chance to really identify and begin understanding where the challenges lie and what our responsibility is here. And if we can't work together, how are we going to be able to provide clinical care, education, support, all that to the folks who want to come to Downstate? We talk about our campaign, Keep Care Close, and that is a critical piece for what we do here. We want to keep the care close, and we want to make sure that people feel comfortable walking in the door no matter who they are. They should not have to identify who they are. They should not have to say, this is what I am, this is who I am, this is what I believe in. They should just be able to walk in and say, I need care. And I am so grateful that I know the folks that we work here with at Downstate are those people. It is what we do from a clinical perspective, an academic perspective, and just a genuine humanity perspective. We're here to provide care to a community where 90% of the people need support for their insurance. We can't turn them away. We don't turn them away. We want to make sure that people do what they do, and that's why they come here. And for folks like Mr. David, hi, Mr. David, how are you? For folks like Mr. David and others who are in the space of advocating beyond what we can do for ourselves, this is why these conversations are so very important. if we don't have people like Mr. David fighting for a Marriage Equality Act, for work through Gilead, and thank you for that. I may come back and ask you to talk a little bit about Gilead. It's important for us to know where we stand. If we don't have the support behind us, we can't go anywhere. And if we don't stand behind each other, where are we 5, 10 years from now? What we're faced with coming from Washington, D.C. requires us to be our brothers and sisters keepers. I mean, I can talk about this and stand on a soapbox all day long, as I often do. But, you know, when you hear things that you know are blatantly wrong and forget unconstitutional, I mean, where's the humanity? This is what we're talking about. And I think we're struggling more against humanity than we are against some of the other things. So I urge you all to pull out that humanity that we know exists, and that generates the feel for what we need to do from an advocacy perspective, a getting out there, walking, stomping, crying, screaming, whatever we need to do. I do have one question, Mr. David. I saw that you were nodding your head when Dr. Jacobson mentioned the HHS data and the SOGI information. Could you elaborate on the head nod and why that gave you the response that I saw?
I was just referencing in my mind the importance of data, that if we take it out of the abstract, yes, this is important, right? Sexual orientation data, gender identity data. But if we take a step back from the disparities, right? Because it's important for us to know when we collect this data how these communities are affected or disaffected in certain ways. But it also affects two other things. One is public investment. Without the data, government is not going to invest in communities that are maybe disproportionately impacted by certain conditions. So that's one. Second, and I think equally as important, it goes to whether or not these communities will be recognized to even exist. If you don't have data saying that there's X amount of LGBTQ people, you could argue they no longer exist. We've seen this movie before. So there's a reason why there is an interest in eliminating data with respect to sexual orientation and gender identity, because you can then argue in a court of law that this is a minority of a minority of a minority, or the argument with respect to disparate impact or disparities you can't make in the same way if you don't have the data to actually advance those claims. So I was nodding because when we think about data, I understand it's incredibly important when we think of it from a clinical trial perspective, or we think about it in terms of science. Very important, but equally as important is whether or not we will be able to argue that in New York State, we have X amount of people who are LGBTQ, and as a result, we should do X. Recognition in existence is just as important as the disparities in the public investment.
Thank you so much for that. I know that we will never have enough time to have these conversations the way that we need to. So I encourage you to keep working with us, and maybe we can bring Mr. David in for a full conversation with us, depending on his schedule, because, you know, and I appreciate, thank you so much for making the time for us, and I know that everybody's calling you, so I appreciate, you know, the opportunity that you took to spend time with us. Maybe we can get you back in for a fuller conversation, because this conversation is just, we're just scratching the surface here. But if we don't keep having them and continuing to make the noise and to make the noise about what is critical to us, we will never get anywhere. And if we're not getting anywhere, we're not heard. And we're talking about a circumstance where policies are coming down left and right, and we're not sure where the courts are in all of this. So it's up to us to continue making as much noise as we can. We have a whole community around us that needs us. So I just want to say thank you all for being here. I want to thank the panelists, our moderator, Mr. David, Dr. Roman, Dr. Benson, Dr. Jacobson, Dr. Rappaport, and Dr. Nuwere. Thank you all, and thank you all for being here in person, and for those of you who joined us online, thank you so very much. We look forward to seeing you, and we'll see you at the next one.
Communications team, and thank you everyone for joining us. Have a good afternoon.